I will introduce the first session, and please, Goran or Yves.
So, the first speaker in this, so the session is new, as usual, news in non-Leftman bifurcation PCI, something we do since many years now. And the first presentation will be by Asahi Oshima about bifurcation subgroup analysis for the multivessel talent trial.
Thank you. My name is Asahi Oshima, and it's my great pleasure to give me an opportunity to present our study today. I'm presenting this talk on behalf of Professor Yoshinobu and Professor Patrick Royce, and also on behalf of the multivessel trial investigators. So as we all know, bifurcation lesions continue to be represent a challenging subset of lesions in interventional cardiology, and it is closely related to the worst outcome. In this study, we aim to evaluate the feasibility of applying the main across distal site to MATS2 classification system in a randomized PCI trial of patients with de novo 3-vessel disease without left main disease, and to report contemporary treatment strategies for the bifurcation lesions adopted by the European operators. So briefly, multivessel talent trial is the multicenter RCT comparing the patient outcome among superfluous stent and synergy stent. In this trial, we apply the best PCI practice encompasses functional lesion assessment by QFR, stent optimization with Yves OCT, and CTO experts and short TAPT. The primary endpoint is a patient-oriented composite endpoint, and the one-year follow-up has been finished, and the main result will be presented at this year's TCT by Professor Royce. So I would like to thank all the collaborators here. So this is the study flowchart. In this multivessel talent trial, there was 4,052 lesions intended to treated. Among them, 595 lesions were bifurcation treatment. For that 595 lesions, assessment of MATS2 classification and the data entry in ECRF by investigator was attempted. So this is the example screenshot of the ECRF. We used iDataFax for this trial. In this trial, the ECRF-based MATS2 classification was successfully achieved in all bifurcation lesions. So this is the summary of the result. So in this multivessel talent trial, among 595 lesions, 410 lesions were treated with a single stenting technique, and 185 lesions were treated with double stenting technique. So this slide shows the detail of the single stenting technique. Among 410 lesions, most frequently used technique was a main vessel crossover stenting. It was 361. And the most frequently used ballooning technique was POT, followed by the chart. The second most frequently used technique was inverted A, main vessel to side branches stenting. It was 39 lesions. For that, also POT was frequently used. There were only few side branch first and distal main first technique was used. So this is a summary of the 595 bifurcation lesions. 410 were treated with a single stent technique. The most commonly used technique was main branch crossover stenting, followed by main vessel to side branch. The most commonly used ballooning technique was POT. So this slide shows the detail of the double stenting technique. There are 40 kilot. There's 92 inverted kilot. 52 DK crush, 12 inverted DK crush, and 10 V stenting. So this is the summary. 185 were treated with double stent technique. The most commonly used technique was kilot and inverted kilot, followed by step decay crush and inverted step decay crush. So when we compare with the historical cohort, IBIGS, COBIS, global leaders, and multivessel talent, as the multivessel talent trial targeted the patient with de novo 3-vessel disease, double stenting technique were relatively more frequently selected compared with the historical cohorts. So when we compare the lesion treated with a double stenting technique in the MVT, global leaders, and the COBIS trial, compare with the historical cohort, among the double stenting technique, MADS A and MADS inverted A was the most frequently used in the multivessel talent trial. So this is the conclusion. The ECRF-based MADS2 classification system proves feasible in a 3-vessel disease trial utilizing contemporary bifurcation technique. Among 595 bifurcation lesions, 410 were treated with the single stent technique, most commonly used main branch crossover stenting plus POT. The remaining 105 lesions were treated with the double stent technique, with kilot being the most frequently used, followed by the decay crush technique. Thank you for your attention.
Okay, presentation is open for questions or comments. Anybody in the panel?
I think it is not the first trial where you were using MADS classification. There is one or two others, no, Patrick? Global leaders will also use the MADS classification. It's not the first one, yes?
So we used the MADS2 classification.
Yeah, but is it the first time you use this classification for a trial? No. Patrick? The second one.
In global leaders, which is 16,000 patients, okay, 16,000 patients, but all comers. This is 3-vessel disease, that was all comers. And that's the first time we used the MADS2, MADS1 at that time, and I was impressed that that was the first information in this huge database which was complete. So because it's visual, the people answer that very easily. When you have a question with a double negation, the study coordinator of the nurse but with this graphic, they can just say, we did that, and there is the chronological order and the distality. So we have to recognize, Yves, that you have created a wonderful instrument for trials.
With Francesco. Francesco was involved also in this.
Yeah.
So it is fantastic to see that the MADS classification is able to reconstruct the procedures. I think that this is extremely important. In the past, there was an attempt in the mega trial done by Patrick to retrospectively collect the data, and it was efficient, and now we have also this incorporated way. It will be extremely important in the future to have this kind of database to be shared probably across different studies, because it will make really comparable the outcomes observed with different techniques, honestly. This is a new way of reporting that I think is extremely important.
Another comment is about the fact that we are facing today the 001 lesions, and that's why we are proposing the inverted provisional strategy. So using this classification, do you think you are able to collect the data from other trials and to have a bigger population to analyze the result?
Honestly, I think that the Medina classification was per se something that allowed to standardize a little bit the comparison between the different studies, because it is accepted since years as the way to report bifurcation studies, patients' characteristics. With the BIF-ARC effort, this has been standardized, and we inserted in it also the MADS classification. This is extremely important because although some refinements will come, the idea that where we place the stent and the type of standardized ballooning steps are very impactful, and I think this is very, very important.
I have to say that for me, one of the key messages should be actually report of clinical outcome according to strategy that was used. I guess this could be possible after TCT. At the moment, I'm sure you have it in the database, but it's not reported.
Yeah, I think what is important is that you have seen that, and I have no conflict of interest, that it is a comparison between synergy and supraflex. And what is interesting with the supraflex, it is in the literature the largest cell of all the stents. So I'm curious to see, I don't know the result, but I'm curious to see if we are going to see some difference in the bifurcation, indicating that to have a stent with a very large cell and surface facilitate all the treatment of bifurcation.
It's a non-left main. That's something that may impact unexpectedly high 30% double stenting in non-left main.
Yeah.
But we will see the outcome, yes?
Well, first of all, thank you very much for that excellent presentation and to showing us the results in that very, very picture-like way. Because I would like to actually lift everything up to what is above, and it is the big art classification and the drive all over the years to get a systematically evaluation of the stent technique used. Because when we compare a single stent towards a double stent, there will be around 50 different ways to do each of them, and each step impact the final outcome. So seeing the charts and the flow charts when it's systematically done make it much more easy to dig deeper into the trials and understand truly what is going on. Not only the technique, but also the way the techniques are carried on. So it's the first time that we really have order in chaos. And that is actually extremely nice to see after 20 years of hard work. So it's just very, very thrilling to see it. So thank you very much.
Thank you.
Thank you very much. Excellent presentation. Now it's pleasure to invite Professor Bon-Kwon Koo, Bifurcation Man of the Year 2019, one of the leaders in the world of bifurcation technique assessment. And Professor Koo will speak about differential risk of ACS in side branches compared to main vessels.
Thank you, Goran and Yves, for the kind introduction and also the kind invitation. So good morning, everybody. So today I'm going to talk about the acute coronary syndrome due to the side branch lesions. It's not that common, but it's not that rare. So this is a slide I presented 2 years ago in EBC while talking about the evolution of bifurcation PCI. And we are understanding that for the clinical risk assessment of the side branch, we are at the stage of the assessment of the degree of lumen narrowing, ischemia detection, and clinical relevance discrimination. So it's good. But when we are talking about the ACS development and ACS risk stratification, we are understanding that there are complex interplay of lumen, plaque quantity, quality in hemodynamics. And the problem we have today for side branch lesion is we do not know whether these metrics and interactions have the same impact in side branch lesions as well. So in that perspective, I can say there are several unanswered questions in side branch lesions like these. And recently, we analyzed EMERALD-2 study to answer some of these questions. So EMERALD-2 study included the patients with acute coronary syndrome with definite culprit in angiography, and we selected the patients who had a CT scan before the ACS event, where the patients were asymptomatic or were stable, and we analyzed the CT in the core lab. And with this lesion definitions, we selected 2,451 lesions in the CT scan, among them 2,011 main branch lesions and 440 side branch lesions. So this is a case example, total occlusion of diagonal branch, acute myocardial infarction presentation. This patient had a CT scan 2 years before the ACS event, and we sent this CT scan to the core lab, and core lab found 7 lesions, 5 lesions in the main branch, 1 in diagonal branch, 1 in obtuse marginal branches, and they analyzed the stenosis severity, plaque burden, adverse plaque characteristics, local hemodynamics, and myocardial mass risk. And we now know that this diagonal branch has become a culprit 2 years later, so we discriminate culprit and non-culprit lesion. So these are the baseline characteristics, typical PCI population, age is 66, male dominant, diabetes is around 30%, and the clinical presentation at the time of ACS was around 2/3 MI, and median time interval between CT and ACS event was around a year. Here are the baseline lesion characteristics, main vessel versus side branch lesions on CT taken before the ACS event. So due to the different lesion definition, degree of stenosis was more in side branches, and accordingly, delta FFRCT is higher, plaque burden was higher, and it is natural that the side branch reference diameter is smaller, lesion length shorter, and myocardial mass risk smaller. But it's interesting that despite the higher degree of stenosis, in terms of adverse plaque characteristics or plaque vulnerability, low attenuation plaque, positive remodeling, spotty calcification, napkin ring sign, and high-risk plaque all were less frequent in side branch lesions. So I don't want to go into the detail of this complicated figures, but this figures is showing the association between lumen, plaque quantity, quality, and hemodynamic characteristics, comparison between main vessel and side branches. And one thing is that in both main and side branches, there was an association between any of these parameters, but the correlations are generally weaker in side branch lesions. And I believe that this is due to the smaller vessel size and smaller plaque volume and more hemodynamic influence due to the upstream lesions. But simply speaking, main and side branches are different. So here is the data about the proportion of couple lesions for ACS. So among the 2011 lesions in 3 years, 16.5% in main vessel lesion has become the culprit of ACS. But in side branch lesion, it's less than half, 7.3%, which means that among all the lesions, despite the higher stenosis severity, side branch lesion tends to cause a less culprit lesion for ACS. And here is the comparison between the future culprit and non-culprit in the main vessel. In terms of degree of stenosis, plaque burden, plaque vulnerability, or adverse plaque characteristics, or hemodynamics, delta FFRCT, and percent myocardial mass risk, all parameters, couple lesions are worse. And this illustrates that by any matrix, worse lesions have a higher risk for the acute coronary syndrome couple lesion. And it's the same for the side branches. Couple lesion tends to have a higher degree of stenosis, high plaque burden, higher frequency of adverse plaque characteristics, higher delta FFRCT, and higher percent myocardial mass risk. So it seems to both main and side branches have a similar lesion characteristic in terms of future ACS culprit. But when we used this 4 common metric to define the risk of the patients or the risk of the lesion or the risk of the ACS risk, percent diameter stenosis, obstructive lesion, plaque burden 70%, high-risk plaque, delta FFRCT. So these are the proportion of ACS couple lesion defined by this cut point. These are main vessel data. But for the side branch data, no matter what kind of metric you're using, you will see that the odds ratio for the proportion of ACS culprit is around 0.2 to 0.4, which means that if you use the same criteria for evaluating the side branch lesion, you'll be ended up with the overtreatment. And this slide shows the general diagnostic performance of high-risk features comparing the main vessel and side branches. I would like to focus only 2 things. One is positive predictive value. So for the obstructive lesion, high plaque burden, high-risk plaque, delta FFRCT, positive predictive value is much, much lower in side branch lesions. in comparison with the main branch lesion is, again, when you apply the same criteria, you'll be ended up with the overtreatment. And when you see the F1 score, which generally represents the performance of each metric in defining the risk, and F1 score is lower in all features, which means that we need a better evaluation tool for the side branches, especially for the risk of acute coronary syndrome. So here is a rather simple regression analysis to define the ACS predictors in main vessel. So for the degree of stenosis, plaque burden, number of APC, or vulnerability, and delta FFRCT across the lesion, it was statistically significant predictor in unadjusted analysis and also the adjusted analysis. But in side branch, it's different. So in unadjusted analysis, all four metric had a significant predictor for the ACS event, but when we do the adjustment, number of APC or plaque character and delta FFRCT or local hemodynamics had a more important role in comparison with the degree of stenosis and the plaque burden. So in summary and conclusion, ladies and gentlemen, coronary side branch lesions have a low risk of ACS than similar main branch lesions. And conventional high-risk criteria for ACS have a limited predictive value for side branch lesion, which highlights the need for vessel-specific tailored approach to side branch lesions. And plaque character and local hemodynamics play a more role in ACS development. That means that we need more adoption of imaging and physiology for better assessment. And finally, a simple conclusion for this long summary is that side branch is not a small main branch. Thank you very much for your kind attention.
Fantastic as always. Professor Ruiz?
As usual, Bon-Kwon, remarkable contribution to the field. I have a specific question. The delta FFR has really emerged over the last 5 years, Emerald 1, Emerald 2, ICFA consensus. But in the literature, you find sometime 0.5, sometime 0.6, sometime 0.13, if I review the whole literature. What is your criteria? Because on one slide I said more than 1, 0.1. So you comfortable with which threshold?
So we used several different cut points. Emerald 1, it was 0.06, and Emerald 2, it was 0.1, and there were several reasons for that. And personally, I now think that 0.1 may be a clinically useful indicator for local hemodynamic disturbance. So we are now using 0.1.
Others?
Very interesting presentation indeed. I really enjoyed it, Dr. Koo.
Thank you.
I cannot understand, however, why the plaque burden is not predictor in side branches comparing to the main vessel in analysis. One can be the small number of events, and you may lose some prognostic value because of that. The other may have to do with the size of the vessel, and CTCA in terms of delineation of the vessel wall has limitations when the vessel becomes smaller, especially in the first generation CT scanners. Do you believe that this is possible? Because plaque burden has been an established predictor of events in all the studies.
Yes, I think that's a very important and very sharp comment, so that when we analyzing the association between plaque burden and adverse plaque characteristics, we found that it was less prominent than the main vessel. And I personally think that this is due to the smaller absolute plaque volume. For the plaque to be vulnerable, I think it needs some amount of the volume. But in side branch, small vessel, so that's the reason why plaque burden may not be a significant indicator, but if the plaque burden has a high vulnerability, they may be the cause. And for the second thing, I agree with your opinion that the CT smaller vessel may have a limited interpretation for that, but we selected more than 2 millimeter larger branches, but that limitation is agreed.
Last question.
So it's also logic to understand if there was correlation between the conventional standard risk factors, the interplay with diabetes, hypertension, dyslipidemia, and the progression in the side branch and the main branch. Did you stabilize this, or what was the case in your study?
Yes, that's another very important question. So that this study is very unique because that we are using the culprit and non-culprit in the same patient, so that it's an internal control study, so that we are not allowed to use the risk factor-based assessment, but I agree that that's an important element to be integrated in our clinical decision making.
Thank you very much,
Thank you.
Kon. So the next speaker is Yoshinobu Murasato, assessment of fractal ratio of vessel diameters in coronary bifurcation lesion by angiography and intravascular ultrasound.
Yeah. Thank you, Yves and Goran, and thank you invitation to the EBC. My topic is assessment of fractal ratio of vessel diameter in coronary bifurcation region by angiography and intravascular ultrasound. In the background, coronary artery branching at the bifurcation is according to the vascular branching law, especially Finner's law, the most clinically useful vascular branching law, which is based on the fractal ratio between the mother and daughter vessels in the quantitative coronary angiography QCA of normal coronary artery tree. Formula is the following: the mother vessel diameter divided by the sum of the daughter vessel diameters is equal to be 0.678. However, the assessment of fractal ratio in the disease coronary bifurcation region has not yet been established. So we sought to investigate, first, a fractal ratio in the disease coronary bifurcation region treated with drug-eluting stent implantation. Second, comparison between fractal ratio by QCA and Z by intravascular ultrasound IVAS. Three, impact of the fractal ratio on rate lumen loss. This is an integrated analysis of a two multi-center registry study treated with drug-eluting stent implantation in coronary bifurcation region. QCA was performed the same QCA software. Pre-PCI case available in the 402 cases. Post-PCI and 9-month follow-up CAG available in 220 cases. IVAS analysis in member cell and side branch in both pre-PCI and post-PCI were available in 109 cases. Fractal ratio was investigated at the site of reference and the minimum lumen diameter emitted site in both QCA and IVAS analysis. Rate lumen loss in proximal member cell, distal member cell, and side branch was calculated in QCA. This is a representative case. In the pre-PCI reference, QCA identifies the reference at the proximal site as 2.70, distal part member cell 2.62, side branch 1.75. These values were using for the calculation of the fractal ratio. Therefore, QCA fractal ratio is measured calculation to the 0.60. In the IVAS analysis, the reference site defined as a plaque-free site, we measured vessel area and calculated the mean value of the vessel diameter at the reference site, and these values are used for the calculation of the fractal ratio. IVAS fractal ratio calculated to 0.68. Therefore, there is a significant difference between that and the QCA. In the MLD side, the MLD values in each bifurcation component used for the calculation of the fractal ratio. And this is a correlation between the mother vessel diameter and some of the daughter vessel diameters correlation. Here you can see both QCA and IVAS positive tight correlation was shown. That indicates that disease coronary bifurcated vessel also have this fractal structure. However, coefficient value is quite different between the QCA and the IVAS. QCA, pre-PCI reference 0.63, IVAS 0.67. So we investigate the change in the fractal ratio, pre-PCI, post-PCI, and 9 months follow-up CAG. In the QCA analysis, the post-PCI reference slightly elevated, and MLD side fractal ratio is significantly greater than that in the reference side. This correlation maintained its follow-up CAG. On the contrary, IVAS analysis, the pre-PCI reference side fractal ratio is 0.66. That is very close to the finesse value of 0.678. Even in the MLD side, the fractal ratio is very similar as in finesse value. This is a distribution of the rate lumen loss in quinta of fractal ratio. The red bar indicates the quinta includes the fractal ratio, finesse low 0.678. In the QCA, there is no trend in terms of the distribution of the rate lumen loss. On the contrary, IVAS analysis, red bar indicates the least rate lumen loss. That indicates the reconstruction according to the finesse law lead to the less rate lumen loss. And this is a QCA-based fractal ratio in previous studies. A tentative fractal ratio was calculated by the mean value of each bifurcation component reported in the paper. Here you can see large vessel is likely to overestimate the fractal ratio because of the mother vessel overestimation or daughter branch underestimation. In the smaller vessel, fractal ratio is likely to underestimate because of the mother vessel underestimation or daughter vessel overestimation. In conclusion, fractal ratio preserved even in the disease coronary bifurcation, which maintains the natural mother-daughter vessel ratio. QCA limitation, which underestimates before PCI, overestimates after PCI. IVAS accuracy provides more reliable vessel assessment. Physiological target, achieving the fractal ratio under the IVAS guidance may reduce lumen loss and promote natural revascularization. This content has been published in the CBIT this year, and thank you for your attention.
Question in the audience? Go on. Maybe I have both of you the same question. You remember the paper of Anne was presented last year, and on the new target for left main stanting. You remember that? And I made an analysis of this with this help. It showed that, yes, aspect of fractal ratio is a factor of no reintervention. So he won't publish that because this is not the topic. So if the neo-intimal hyperplasia is limited by the fractal ratio, when at the end you don't have the fractal ratio, you have neo-intimal hyperplasia. Is it only to correct the anatomy back to the normal, or is it a factor for restenosis? So this is for you too.
So I think that's a very interesting question. So that the natural law actually try to maintain the minimal moisture stress while blood flows, so that that restenosis can be a kind of healing process to reduce the turbulence. But if it is exaggerated, that can be a restenosis. But we don't know where it will be the cut point. And in that perspective, it may be the same question, so that you use the IVAS assessment. Yeah. And I'm wondering whether you use lumen area in the reference segment or the vessel area in the reference segment.
So in the IVAS, we measure the vessel area and calculate the mean vessel diameter.
So that may make sense in some aspect, but the the fractal ratio or the Murray's law are for the flow. So for the flow to make a kind of less turbulence flow, blood flow doesn't matter where the vessel is, but it matters only the lumen. So I'm thinking that the lumen assessment, even by the IVUS, is more appropriate for this kind of analysis, even though there's some disease. But it's my simple suggestion.
Thank you.
This is not Murray's law. This is Finney's formula, which is a bit different, you know, Murray's law and Finney's formula. So, any question?
No, for
Francesco?
me, I mean, just congratulations. I think that the study is very well designed in terms of comparing QCA and adequate IVUS quantitative analysis. I feel that this is recognition for the Yves idea about this relevance, and I feel that this will be something that will be validated in other studies, because anyway it is a small number of studies, but of patients, but it is very, very interesting because it really changes the approach, the concept of bigger is better, that was one of the concepts that for interventional cardiologists who was something in our mind, changes with that. And at the end, I feel that there will be higher safety for our procedures if we try to respect a little bit more the anatomy. And once more, there is the problem with QCA and angiography that is inappropriate, honestly, especially at the baseline.
That is a very important comment because the proportional expansion in each component of bifurcation is very important. Over-dilation in the proximal side because, due to the oversized part or kissing balloon inflation, elliptical stent deformation, such kind of things causes the flow turbulence at the over-dilated side. So proportional dilation at the bifurcation point is very important. So IVUS is very helpful to identify the healthy side, the reference side, the proximal healthy side, distal healthy side, the sideband healthy side. So we should construction the bifurcation as it were. That is very important.
Just a comment maybe also to Prof. Seruyus. I remember the publication of Kubo, and compared to phantom measurements, QCA actually underestimates by approximately 5% measurements, and IVUS overestimates. Is this taken into account, or does it play a role in your analysis?
Especially in the diseased coronary bifurcation, maybe stenting and jailing the side branch, QCA underestimate the side branch narrowing, overestimate, especially the jazz rat and the hazy images after dilation. So actually fractal ratio at the MLD side is higher. That indicates the overestimation of the side branch or distal member cell. So such kind of inaccuracy in the QCA is very problematic.
Yeah, it's even more complicated because the relationship is not linear. So for the big vessel, IVUS overestimate. For the small vessel, is underestimate. So that makes the relationship quite difficult. And I really appreciate the work that the Korean people have done, trying to make a correction based on IVUS adapted to the QCA. That was turned down in the Lancet, but finally accepted in the JAMA. It's an important paper showing that guidance by QCA of guidance by IVUS is similar and identical in terms of MACE and POCHE if you do that correction for the QCA. That's a very important contribution to the field that should be emphasized.
Yeah, guide DES study, yeah. Thank you very much, excellent presentation. And now we invite Dr. Nam, true versus non-true bifurcation PCI strategy.
Thank you, respectable chairman. It's my great honor to have a chance to present my study. Okay. So previous our COVID-2 data showed that the true bifurcation region has a more event rate along to 3 years. And also COVID-3 data showed the left main vessel PCI has a poor outcome than the non-left main vessel PCI. And also, if we detailed analysis for COVID-3 data, we compared one stent versus two stent strategy. In the left side, left main bifurcation, definitely two stent strategy has a poor outcome than one stent strategy. But right side, non-left main bifurcation, there was no difference between one stent or two stent, and event rate was nearly half of them. So there was a significant interaction between treatment strategy and bifurcation location for the risk of target region failure. Although true bifurcation regions are associated with a high risk of complication, the differential prognosis implication of PCI for true bifurcation regions according to region location are unclear. So we would like to identify the optimal treatment strategy for subtypes of bifurcation region, location, and complexity in the current generation DES era. So we have a good chance to collaborate with Italian group. So we merged COVID-3 RIS3 and RAIN Ultra RIS3 with so-called Ultra Bifurcate RIS3. We include more than 6,500 bifurcation PCI patients and 1,800 left main bifurcation and nearly 4,800 non-left main bifurcation. And today, this session is non-left main bifurcation session. So we are focusing on the non-left main bifurcation. Half and half was true and non-true bifurcation. And the primary endpoint was a major adverse cardiac event, composite of cardiac all-cause death and an MI and TLR and stance thrombosis. This is baseline and angiographic characteristics, a little bit higher in the true bifurcationism of diabetes, and about the stable coronary syndrome was more frequent in non-true bifurcation region. And the angiographic analysis focused on this slide. So the upfront two-stent strategy was more frequent in true bifurcation, non-left main bifurcation region, and nearly 23%, and then extremely rare for the non-true bifurcation region. And the kissing balloon, more frequent in true bifurcation region, but pod was frequent in non-true bifurcation region. But anyway, this study showed a little bit low rate of pod technique, so this makes a different result in the later part. If you see the clinical outcome in non-left main bifurcation region MACE, even though it's true or non-true, there was no difference until 3 years, nearly 9% of event rate. If you see the detail, in true bifurcation region, one stent versus two stent, no different. Non-true bifurcation region numerically looks high in two-stent strategy, but it's very small number of patients is statistically not significant. So we may say whether in the non-left main bifurcation, true or non-true, one stent or two stent, there is no difference. If you see the left main bifurcation, although it's a non-left main bifurcation, but we compare the outcome. The left main bifurcation, definitely true bifurcation make higher event rate. If we focus on left main true bifurcation region, even though it's a one stent, two stent, but it's nearly 20% MACE rate until 3 years. It's very high event rate, but no difference between one stent or two stent. If you see the non-true left main bifurcation, two-stent strategy looks definitely higher event rate compared to one-stent strategy. And then predictor analysis for the non-left main bifurcation PCI, definitely clinical risk factor like CKD, low EF, diabetes, higher event rate. And then ultra-thin DES has a lesser event, and then also kissing balloon technique showed a better outcome. As I already mentioned that in this study, nearly lesser than 40% applied the POT technique. So according to previous COVID-2 registry data, when we analyze kissing balloon technique is better than the non-kissing group in non-left main bifurcation PCI because when we analyze QCA, the kissing balloon technique showed improvement of a proximal part of main vessel. It looks like a POT technique. So I'm not sure, but we believe that if we applied more than pot technique in this cohort, kissing balloon technique, will be cannot make a different outcome. Anyway, yeah, it's a kind of a result. And then nowadays we more focus on the invasive vascular imaging guidance. So left main bifurcation, definitely, if you apply the imaging, better outcome. But non-left main bifurcation, even though you applied imaging guidance, we cannot make a better outcome. Although it's observational nature, the study, and then no QCA, all the patient, and then very less use of two-stent strategy in non-left main bifurcation reason. But I may say that we can make some perspective from this study. In non-left main bifurcation, whether true, non-true, one-stent, two-stent, no different, because to make a different outcome, we need more substantive myocardial mass. But the side branch has a lesser chance of enough myocardial burden to make an outcome difference. And then left main bifurcation, as we know that not only mass, but also ischemia is also important. So true bifurcation is definitely higher rate of ischemia per side branch, so it can make a different outcome. So ladies and gentlemen, it's my last summary slide. Is there a difference between true and non-true bifurcation? No, in non-left main bifurcation PCI. So nowadays we too much applied our resource and energy for non-left main bifurcation, but it is very hard to make a difference in non-left main bifurcation. But left main bifurcation, definitely yes. So we need more focus on the left main bifurcation for the treatment of side branching. So provisional one-stent strategy should be the preferred approach for treatment of any type of non-true bifurcation reason or non-left main bifurcation reason. Thank you very much for your kind attention.
Fantastic and provocative as always. Thank you for bringing field to upper level. Comments from the audience? Yeah, Maciej.
Just one question regarding the IVUS use, because we saw the opposite influence of IVUS left main. It was in favor of the good result. In non-left main bifurcation, the IVUS, it seemed like it's worse, the outcome is worse even. So did you check in what way the IVUS was used? Because I think for the left main, the IVUS was used from the very beginning of the procedure, and perhaps in non-left main bifurcation, they use IVUS only if something already happened, like some problems or the result was not optimal. And that's, I think it may be this kind of bias. That's why the IVUS did not show any advantage in non-left main bifurcation. What do you think?
Yeah, it's a very important comment. I totally agree with your opinion, but in left main bifurcation, we have, as an October trial, so it is very high chance of not only just the expansion, but also the unintended stent deformity. There is an acute complication which can be detected only by invasive imaging, not by angio. So that kind of thing can make a different outcome in not only the later part, but also very early part. So I believe the complex procedure in left main, that can be an important part of imaging guidance. Not only your opinion, I agree with your opinion, and also the different side.
Okay.
If you look on the forest plot, left main versus non-left main image guidance overall, in all randomized studies, you see clear benefit in the studies in the left main. Mm-hmm. But actually none of the studies absolutely showed any benefit in non-left main through bifurcation. So mm-hmm. I believe that your findings are actually confirming what was documented in randomized studies. Francesco?
Well, I have a comment that on a chart that impressed me, that is, and it is not the first time in the literature, where in non-true bifurcations treated with one stent, you have a better outcome if you implant a single stent. I mean, it is well established. I feel that it is important that we have this in mind when we enter in the cath lab to treat a non-true bifurcation. Because if all our procedures should be focused in ending up with a single stent, the patients who will receive a second stent will be exposed to no benefit and clearly a significant hazard in the long term. And we now know much more as compared to what we knew during the enrollment of these studies, because the systematic, the crossover is followed by POT, the use of kissing just in the case there is carina distortion, or, I mean, with appropriately sized rewiring into the distality. I think that all of this stuff can increase the efficacy of our procedure, preventing the need to second stent implantation in non-true bifurcations. That is probably a focus that is also on the interest of much more interventionalists, because the even younger fellows are performing non-true bifurcations, and they should do that really properly.
Yeah, totally.
Did you analyze in the non-true bifurcations, did you analyze the reason for the two-stent use in those? Because you might have a problem, and that might be a prognostic indicator in the procedure.
Yeah, it's a very important comment. Unfortunately, this is a retrospective kind of loosely merging data, so we cannot analyze that kind of cause. So this is a big limitation of this study.
Well, excellent presentation and very, very important result. And I really, really like the conclusion, because it supports what we have been advocating for 20 years. So very, very nice. But I do have the same concern as the panel, because if you get a two-stent in the Corbis trial, it might be because the one-stent strategy didn't work. So it ended up with two stents. And then it is actually, from the beginning, a one-stent strategy. But it's analyzed as a two-stent strategy, which was a one-stent strategy that went bad. And that actually imposed a major risk of malconclusions.
Yeah. Actually, this is a merge of three registry data. But the Corbis 3, we have a QCA data analysis, and then that we have a cause of a two-stent strategy. But that was the prospective decision. So it means operator decided two-stent strategy initially, because in Korea, nearly two-thirds of two-stent strategy doing the crushing technique. So operator already decided two-stent strategy, and then their outcome was very poor. So it means we are really over treatment for the, yeah, that's why nowadays we move from the two-stent strategy. Most bifurcation is from the two-stent strategy to one-stent provisional strategy nowadays.
It's a great set of data, and it's reassuring that it shows us all what we want to see, positive reassurance. But do you have enough data there to look at KISS versus no KISS in the left main true and non-true bifurcation? Yeah. Have you looked at that?
Yeah, actually, yeah, I showed on today is a non-left main bifurcation. But the left main bifurcation, even though it's a non-left main bifurcation, kissing balloon technique showed a better outcome. But the left main bifurcation, there is no difference whether you do the kissing balloon or not. So I believe, as I already mentioned, that in this study, we do the lesser part. Part is very important, the proximal optimization. So that's why the non-left main bifurcation kissing balloon technique showed the proximal optimization. But in left main bifurcation, usually, yeah, imaging guidance and then already performed the optimization. Yeah.
Thank you.
Okay.
Thank you very much. So the next speaker is Ovidio De Filippo. Final kissing balloon dilatation in patients with coronary bifurcation lesion treated with an upfront provisional stenting strategy.
Good morning, everyone, and thanks to the European Bifurcation Club for inviting me to discuss the impact of final kissing balloon dilatation in patients with coronary bifurcation lesion treated with an upfront provisional stenting strategy. As we know, thanks to the data gathered by this society and the progressive recommendation, we now know that provisional stenting is regarded and recommended as the preferred strategy to treat coronary bifurcation lesion, with the intention to keep the procedure as simple as possible and aim aiming to minimize the number of steps and of stents that are required in treating a bifurcation lesion. The provisional stenting strategy is composed by several steps, but basically only 2 of these are mandatory, as shown in the left part of this picture, that are the delivery of a stent that is sized according to the distal main vessel diameter and the proximal optimization of this stent with a post-dilatation. If the main vessel has an optimal result and there is a side branch patency, the procedure could also stop at this step. However, if the side branch requires further intervention, this should go through a final kissing balloon dilatation and a report. However, to date, there are no sufficient data to support a routine utilization of kissing balloon, as shown by this broken green arrow in the bottom of the picture. And also, as correctly pointed out by the latest consensus document, each single step in treating a coronary bifurcation may be associated with some pitfalls, and as such, it is still relevant to provide data about usefulness and safety of each recommended step, such as kissing balloon, to simplify procedure and, if feasible, keep good outcomes. The impact of a routine kissing balloon strategy has been explored in several works and mainly observational, as summarized in this meta-analysis that show that the strategy of a routine kissing balloon in provisional stenting is not associated with a reduced risk of cardiac death, but it may be associated with a reduced risk of side branch restenosis with a higher risk of main branch restenosis. A previous work by our group, published in 2020, showed that in provisional stenting strategy, kissing balloon is not associated with improved outcomes, while in patients treated with a 2-stent strategy, kissing balloon may be associated with improved outcomes, mainly in terms of target vessel revascularization and target lesion revascularization, with a particular focus in keep the overlap between the 2 balloons very short. In particular, the optimal outcomes come when we use an overlap shorter than 3 millimeters between 2 balloons. As we said, we need to keep on gathering evidence and collecting data, and for this purpose, we merged the data of patients included in the COVID-3 registry, the RAIN registry, and finally the ULTRA registry, providing a dataset of 5,670 patients treated with provisional stenting strategy. The features of these patients were matched with a propensity score matching, and after this matching, we included 1,784 patients in each group that are those treated with final kissing balloon and no final kissing balloon groups. The primary endpoint was the major adverse cardiovascular events, that is a composite of all-cause death, all myocardial infarction, target lesion revascularization, and stent thrombosis. As secondary endpoint, we explored a composite of target vessel myocardial infarction or target lesion revascularization that we defined as lesion-oriented composite endpoint. And as further endpoints, we explored the single component of MACE. To ensure homogeneity between the registry, the follow-up was censored at 800 days. After the matching, as shown in this table, the baseline features of patients included in the 2 groups were basically well balanced, with the majority of patients included after an acute coronary syndromes, and the distribution of common cardiovascular risk factor being balanced between the 2 groups. As for the procedural features of patients included after the propensity score matching, we know that we can see that the most frequently treated bifurcation lesion was the one involving the LAD with diagonal branches, and we can observe a very low, albeit in line with observational data, utilization of intravascular imaging. These are the results. Final kissing balloon was not associated with a reduced risk of the primary endpoint, that is MACE, as shown both in the Kaplan-Meier curves in the left and in the table on the right. However, the strategy of a routine final kissing balloon was associated with a reduction in the risk of all myocardial infarction stent thrombosis, the reduced risk in myocardial infarction was partially driven by reduced risk of target vessel myocardial infarction, and overall, this resulted in a reduced risk of lesion-oriented composite outcomes. We also explored the results in 4 subgroups of patients that are those treated with side branch lesion greater than 20 millimeters, those treated with a side branch diameter greater than 2.5 millimeters, those treated with true coronary bifurcation or unprotected left main. And results were mostly confirmed in patients treated for bifurcations with a side branch diameter greater than 2.5 millimeters. As we can see, there is a significant reduction in the risk of lesion-oriented composite outcomes, and those treated for a true coronary bifurcation with a significant reduction in the risk of lesion-oriented composite outcomes driven by a reduced risk of target lesion revascularization, while no significant differences emerged in those treated with long branch lesion or unprotected left main. Of course, there were a few patients treated for unprotected left main, and these results should be paired with the result for the unprotected left main should be paired with one suggesting that lesion with side branch diameter greater than 2.5 millimeters have some benefit with final kissing balloon, suggesting that there is not the localization of the lesion, but probably the relevance of the side branch diameter in supporting the necessity of recrossing and provide final kissing balloon or not. Of course, the study has several limitations. This was a retrospective study, so despite extensive adjustment with propensity score matching, the impact of some unmeasured or unknown variables cannot be excluded. In particular, we acknowledge that limited data were available with respect to the utilization of POT, proximal optimization technique, that is a variable that is pretty difficult to collect in a retrospective registry. And also, as stated before, there was a very limited use of intravascular imaging, albeit we have to say that this is in line with real-world reports. So in conclusion, in this large real-world registry of patients treated with provisional stenting strategy for coronary bifurcation lesion, final kissing balloon was not associated with a significant reduction of MACE over a follow-up of 800 days. However, final kissing balloon was associated with a significant reduction of lesion-associated adverse outcomes that were mainly driven by a reduction in target lesion revascularization or target vessel myocardial infarction. So we still may say that final kissing balloon was useful for patients, particularly for patients treated for true coronary bifurcation or for lesion with a side branch diameter larger than 2.5 millimeters. So final kissing balloon is still useful. It is not associated with a reduced risk of minor adverse cardiovascular events, but still it may be useful in reducing the risk of target lesion revascularization or overall lesion-oriented composite endpoints. Thank you for your kind attention.
I don't know if Dr. De Filippo is connected. No? Okay, so we can discuss inside. If you have any comments or questions. Yeah. Helen.
There's an interesting inconsistency that for a large side branch there was a benefit, but for left main there was no benefit, and that doesn't make sense at all. I can't explain.
Maybe part of the data which could be explained in the same way, with the same mechanism. Extremely low rate of POT initially, and then correction in non-left main with the kissing, probably corrected proximal expansion. I mean, it's good to see that we have consistency, you know. Although we don't have standardized procedure, POT side, this Francesco will elaborate after this discussion. We see consistently less TLR, so from the beginning, and now we see individual components like stent thrombosis, target lesion, related MI. I believe we are on the way to selectively apply kissing, probably, as you said, for large side branches, being very careful about recrossing point, because kissing seems to be one of the most sensitive steps If you cross proximally, you can harm. If you cross distally. I don't know if you have other comments. Yeah, Remo is there. Can we have microphone for Dr.
I agree with you. My experience is that someone yesterday asked me, when you don't do any kissing? So I do systematic kissing at French style, systematic kissing to a patient, but sometimes I don't do kissing. And say, why? Because I'm not sure if I am distal or proximal. So when I'm not sure that I distal crossa, if the side branch is okay, I avoid to do the kissing because I can harm the patient to create this neocarina. This is the only, when I have suspicion that sometimes there is also a method to discover OCT. It's expensive, but sometimes if you repot after kissing, and then you take the same balloon that you use for kissing, and the balloon will not cross, means that you were proximal.
Yeah, you shifted metal.
You close. And then if the balloon doesn't cross, I can say, okay, I will leave like that. It's better to leave the door closed compared to have a long neocarina in the middle.
Yeah.
There's also a slight concern with the enthusiasm for drug-coated balloon in the side branch, that in situations where people have learned that actually a kiss might not be necessary, but they're going to do it anyway because they want to put some drug in the side branch. And I think that's a concern because we might end up doing bad kisses just so that we can get some drug in there, which we know that we probably don't need.
I agree with you, but we really don't have data to base discussion except for maybe what we yesterday saw in the Visible Heart Lab experiment that was done with angioscopy. You really see drug. Actually, you see contrast on the vessel wall, and it's very vulnerable. So this component also should be in mind when you decide kissing or not. With kissing, you will definitely strip much more drug. But we need to learn more. So thank you to Dr. De Filippo. And now I invite my colleague and friend Francesco to present the CRABIS results.
Thank you, Goran. So these are my conflict of interest. So the background for the CRABIS trial. Provisional stenting is the gold standard for PCI in unselected bifurcation lesions, but the optimal ballooning technique for eventual side branch treatment has not been established so far. So the aim of the study was to compare the stent configurations obtained by two side branch ballooning techniques after main vessel stent implantation in unprotected left main or large bifurcations. Why in that? Because the measure modifications associated with the side branch intervention are more apparent if we have bigger balloon in the side. And the side branch ballooning techniques which we compared are pot side pot and pot kissing pot that are actually the one that in this consensus have been emerging according to bench tests as the most promising one. And I want also to emphasize that the sequence of pot kissing pot, although as some bench test in favor, has not been systematically applied in any trial. I think it was recommended in the EBC main, but not applied systematically. So this trial was a unique study program that cannot have been done without the environment of the European Bifurcation Club, because indeed what we had was a preclinical phase that I think is extremely important in the future, will be extremely important in the future when we are dealing with technique refinements. And then a clinical phase that started when the results of the first preclinical phase have been completed. The preclinical phase compared these two techniques in the Visible Art Lab procedures and had a multimodality imaging that incorporated angiography, angioscopy, OCT, and micro-CT. The clinical phase, obviously, had limited access, so we had angiography and OCT. The preclinical phase results have been published in Circulation Cardiovascular Intervention and show, first of all, documented that it was the first prospective randomized trial inside this unique preclinical environment. Bifurcation PCI were conducted with these two techniques, achieved different configuration of the stent. Pod-side pot had a better preservation of the circularity in the proximal main vessel, and pod-kiss pot had better expansion and apposition at the level of distal main vessel, as well better side branch scaffolding. These two aspects have never been emphasized in other environments, but here there was no atherosclerosis. So the clinical phase was a monocentric, non-profit, prospective randomized trial. And the inclusion criteria were, the main inclusion criteria were, stable or unstable patients, but without acute myocardial infarction and cardiogenic shock. PCI planning that, according to the decision of the operator, included at the beginning provisional stenting with image guidance. We are dealing, with the large bifurcations, so it is recommended doing this. And it focused on de novo coronary lesions involving the left main bifurcation or a bifurcation lesion with large branches, which means 3.5 distal main vessel and more than 275 or more for the side branch. So 60 patients were enrolled. We performed in all patients crossover stenting and POT. Then the patients have been randomized to pod-side pot on top of distal rewiring with side branch dilation, followed by POT, keeping attention to try to reach the carina but not going into the distality. And regarding pod-kiss pot, we had distal rewiring, kissing balloon inflation with minimal overlap, if possible, into the main vessel, and for sure minimal protrusion inside the side branch, so no long stents, and re-POT as well. And then we perform OCT in the main vessel at this stage. So the classic OCT measurement went done, everything was done, but the primary endpoint that was set on the basis of the preclinical phase was minimum stent expansion at the distal main vessel, because this was the true novelty of the Visible Heart Lab experiment, that there was the possibility to jeopardize the main vessel with the sequence of pot, side pot. The characteristics of the study, the clinical characteristics are here. Nothing special. Quite low risk on clinical ground. But we had more than 80% of the patients with unprotected left main and large bifurcation as well. And some Medina 1-1 inclusion were included in, it is a quarter of them. And regarding the plaque, no differences between the two study groups. And regarding the procedure, we have been mainly done with radial access. The predilation of the main vessel was systematically performed, and we used a everolimus drug-eluting stent and zosterolimus eluting stent. Honestly, much more zosterolimus eluting stent, the Onyx stent. These are the QCA characteristics showing that there is a diameter that is large into the main vessel. Sorry, the characteristics of the stent we implanted. The stent were 3.9 on average, and the POT balloon was 4.5 on average with no differences, so really big bifurcations. The side branch dilation with the big branches both in kissing and in the side branch, so 3.0 on average. Regarding the stent expansion, primary endpoint, this is the comparison, the final result for it. We had that we confirmed in the human the fact that pot-kiss pot increases significantly the stent expansion at the distal main vessel. And we also noticed, probably as expected, the fact that there is better expansion of the stent into the bifurcation core with no differences into the proximal main vessel. Regarding stent apposition, there was also significant differences that were being noted, including the presence of higher malapposition with the side pot at both the bifurcation core and the distal main vessel. Stent eccentricity, one of the things that has been more advocated, and all the bench tests which compared the kissing with the POT, but with kissing not followed by re-POT, showed the differences, and here we had no significant differences. You see that there is some more scattering into the bifurcation core with pot-kiss pot. This means that if we are not precise, we cannot restore the round shape with the POT. So it depends probably on the dedication of the operators, but anyway, on average, there is a trend which is not statistically significant. I want to conclude my presentation with some examples of the 3D OCT that show this phenomenon. On the left, you have pot kissing pot cases, and on the right, the pot side pot. You see that the yellow lines, the yellow struts are apparent just in the pot side pot, and they include not only at the area where the side branch is, but also into the distal main vessel. So it seems that the stretch that is induced by large ballooning into the side branch creates distortion and malapposition in the distal main vessel that at least should be anticipated and probably corrected if we want to follow this sequence. And what is also interesting to me, probably more interesting than the other stuff, is related with this phenomenon. You see that there is with pot side pot, the not wide scaffolding, entire scaffolding with the stent struts inside the side branch that it translates in some malapposition over there that can jeopardize, I think, in the case you need something more, the possibility to do. On the left, you see that there is really fantastic scaffolding and no floating stent struts into the area of the bifurcation. So the conclusions are that during stepwise provisional stenting in left main or large bifurcations, the pot-kiss pot sequence is associated with better stent configuration than pot side pot. In particular, at the bifurcation core, we have better stent apposition and side branch scaffolding, and into the distal main vessel, we have better stent apposition and stent expansion, and the study has been published in Jacques intervention. Special thanks to all the team, because I mean, you understand how meticulous was the work during this trial, and in particular to Francesco Bianchini. Thank you.
Thank you, Francesco. So questions or comments? Yeah, Manuel.
Francesco, congratulations for this important work, because you have the preclinical phase, you have a clinical study, so it's absolutely complete. My question or my concern is about the pot position. You compare the formation in the stent, expansion, non-apposition, just around the side branch origin. But if you perform the pot proximally, you does not correct anything. If you perform the pot distally, you correct everything, but produce compromise of the side branch. So in this presentation, you do not provide the status of the side branch, but I remember that in the paper, the stenosis was even worse in the pot side pot. Was correct?
Yes.
So you have any comment about this situation? Because Dobry Vasilev proposed the pocket technique to avoid this problem, no? with the pot.
So first of all, this is not, let's say, something that is associated with the strong clinical outcomes, because some malapposition, especially not if not related with other problems, I don't think that automatically should change our perspective. But anyway, why kissing was invented? It was invented because we knew that if you balloon with a large balloon the side cells of a stent, you induce a measured distortion into the distal main vessel. So this is, if we endorse the pot side pot, we are doing this systematically, and at the end, the final result we will leave in the patient will depend on the position of the RPOT balloon. As you highlighted, the RPOT is not so easy because you did several stuff. You rewired, you have been able to dilate the stent struts. Then to fix this distal main vessel area, you need really to go with your POT balloon so distal to have the nose of the balloon inside the distal main vessel. And this is, for me, really unpredictable. So during this trial, there was maximal attention in doing much more than I think it is practiced in the regular cath labs without trials or without, even in mine outside the trial. So I think that this is much more predictable to apply this sequence, that is pot, kissing, and RPOT, where the RPOT at the end is done just to restore the round shape, and we saw that there is scattering in the elasticity. So this means that if the operator is imperfect, what we leave is just some eccentricity into the polygon of conference. I don't think that is a major clinical problem.
Question in the back? Yeah.
Francesco, such a pleasure to see your continuous research as it goes from bench to the clinic. So I have to congratulate you on that. Did you look at the contralateral stent apposition in the pot side pot compared to, obviously, to kissing?
Yes, we did, but we knew that this was a problem that should be fixed. So honestly, we didn't see a lot of this problem. The malapposition we found were mainly into the bifurcation cord related with the fact that the stent did not scaffolded toward the side branch on top of distal rewiring. So, because it is effective if you go close to the carena, and we went there. The problem is that there is the other problem, that is the main vessel jeopardization that necessitates the nose of the POT balloon to be fixed, or probably another step that will be repeat distal ballooning for the main vessel. So this is coming.
Dr. Murasato?
Yeah. Congratulations about the great study. And we also similar trial comparing the port side and conventional kissing balloon infiltration without a port. In such a trial, we failed to demonstrate the efficacy of the port side procedure because the port did not provides sufficient dilation in the polygon area. So that is because of the inappropriate position of port. More proximal part as the port was dilated and the polygon area did not significantly enlarge. And another point is the side branch balloon position. We recommend the short balloon, ultra short balloon, or proximal balloon H balloon dilation at only a side branch ostium. But it is very difficult to the accurate position. So therefore, the long balloon across the side branch causes such kind of side branch opposite side malposition is likely to occur. That is an important point to the failure of the port side port technique.
Yes, so, I know very well, Yoshi, your studies regarding how to perform pot side pot. So it is true, it is possible that the big balloon that are protruding like we use for kissing are not the most appropriate phase. But in my mind, all of these refinements, I mean, maximal precision to the RPOT, maximal attention with short balloon and with the difficulty to keep them in the correct position. I don't think that makes, in the average operator practice, this sequence more comfortable than the Potki spot.
We have 3 more questions, so please, short questions, short answers.
Just
First.
a very quick one. I mean, I remember sort of the micro-CT data from Nicolas Fouin, and it was showing essentially that if you sequentially fenestrate or kiss, it didn't matter. I mean, is it just the stiffness of the vessels versus the model that explains the difference here?
So the model here, we are dealing with the human, honestly. So I think that it is, we know that there is a huge variations in the stiffness of the vessels according to the plaque components we have. So it is sure that the answer to the different steps can be completely different in different patients with different plaque characteristics and distribution.
If I remember Joanna correctly, there was no pot in Nicolas Fouin. He just did kissing or repot in the other arm. That caused the
Goran, and this is extremely important because I think that the addition of a RIPOT is something that is extremely important in kissing to check several things. First of all, there is the possibility also to have huge overlaps that do not only induces some eccentricity. Sometimes it also creates some step up into the proximal main vessel that may create flow turbulences. And
Dr. Magdi?
Yeah, so you conducted this study on large side branches. So practically, what should be done to the small side branches?
I cannot answer without a dedicated study, but I think
Helen.
that during this session, we saw that the number of manipulations we had are have probably less impact, less possibility to have clinical impact when we are dealing with the small side branches due to the fact that the myocardial mass that is supplied is much less. So
last question, Helen.
It's just a quick comment that it was really interesting what you saw in the Visible Heart Lab and what's come out, because one of the things that we always forget, I think, in a bifurcation is the distal main vessel. And you know, in a straight line stent, you always post-dilate, but when you're obsessing about the pot and the side branch, you forget the distal main vessel, which also needs post-dilating. So the conclusion of what you're telling us to do is that at least we also post-dilate the distal main vessel.
Thank you.
Thank you very much, Francesco. Thank you to Yves, panelists. And I invite Professor Ruiz to take stage.